short time for question answer. Our first keynote speaker, Dr. Arun Kumar Singh, and our Sri Naveen Kumar. So, any questions from students? Please raise your hand. Our volunteers will take the microphone to you.
A form of question to Professor Singh. Rather, before putting that line, I'd like to thank you, sir, for a very valuable talk which you have taught. And the relation is basically based on the relation of the child and mother. The last slide which he shared with us was the cradle and the lap of the mother. By saying that, एक शेर मुझे याद आता है, तो मैं चाहता हूँ कि डॉक्टर प्रोफेसर सिंह के खातिर मैं ये शेर आपको नजर करूँ। शेर ये है कि मैंने यूं तो छुआ है बुलंदियों के बहुत सारी निशानियाँ, मैं तो यूं छुआ है बुलंदी के सारी निशानियाँ, माँ ने गोद में लिया और मैंने आसमान छू लिया। So that was very fine for the last slide, sir. Thank you very much. This I have already told you, sir.
Role from hypothalamus of the mother or immunotherapeutic role. I want to get explanation from you.
Role during the birth, right?
For the development of the brain of the
Okay. So I'll switch over to Bengali. This is a very important question. আমি যখন ডাক্তার হলাম, when I became a doctor, I thought a delivery is a physical phenomenon. পেট কেটে বাচ্চাকে বের করে দাও, cut the abdomen and take out the child. That's delivery. After so many years of my research and work, I have found a very interesting phenomenon, and you all can do this work. If you give privacy to the mother, even animals do not deliver if you don't give privacy. If you give privacy, if you give birth companion, if you give dignity, then lot of hormones come out from the brain of the mother. They change the entire circuit of the mother and the child forever. If I do EEG of the mother and the child, I will find it is a synchronized EEG. Ma ja bhabche, bachcha aki bhabche. Absolutely the same waves are there. This is phenomenal. So hormones like oxytocin, মা এবং বাচ্চার রিলেশনশিপ সারা জীবনের জন্য তৈরি হয়ে যায় ওই লেবার পেনে, if I allow those neurotransmitters to come out. If I don't allow, it doesn't. I will tell you a small story. There was one case in which a mother killed her daughter. It was from Assam, Shiny Bora case. I think you must have read Peter Mukherjee, Shiny Bora. I was slightly surprised. How can a mother kill a child? Actually, three things happened. During the delivery, father was not there. The mother and child were separated just after the delivery, and a C-section was done. You did not give time for the mother to understand the child and the child to understand the mother. And this is done through neurotransmitters which is released from the brain. I can dwell upon it much more, but for the time being, the short answer is we are coming in the way of the mother and newborn relationship, which is going to be forever. This is in all mammals, not only in human beings. But human beings require the most because child is neurologically immature. A calf can be separated from the mother, but a newborn cannot be separated. The whole development of the newborn brain, 12 centimeters is gained in the first year of life. In the second year, only 2.5 centimeters. Take a head circumference and measure. Take ordinary tape. 12 centimeters. Can you see the velocity? So the first year of life and the labor room should be changed. I'm sorry to say, almost the entire world has changed, excepting few countries like India, Pakistan and Bangladesh. change. We still think birth of a child is a mechanical process. It is not a. And again, going back to literature, if you don't read literature, you will not. Tagore in his poem said, you become a mother not when you conceive. You become a mother the day you think you are going to be one. সেদিনই আপনি মা হয়ে যান যেদিন আপনার মাথার মধ্যে আপনি ভেবেছেন, সেদিন থেকে সব পরিবর্তন হয়ে যাবে। All neurotransmitters of the brain change. This is how nature has designed. We come in the way of the nature.
Any more questions, anybody?
Yes, yes.
Good afternoon, sir.
Yes.
Sir, you just mentioned that in the first year there is a huge growth in the newborn spread. So is prolactin has anything to do with this stuff?
Yes, absolutely. So let me answer you. Milk is not in the breast, milk is in the brain. I was doing this research, I was making a milk bank and I was trying to copy the West. I was thinking by appointing a nurse I will be able to get milk. I failed. I thought of giving a medicine to the mother, galactogogues. It failed. So what I did was, I put the music according to her culture. I made her relax and milk started coming. So even milk comes from the brain. The prolactin and oxytocin both are released from the brain. Controls your entire body.
Brain development of a child. So, and in your introduction you said that how before 1945 many great minds have been born who have led the world to a different stage, and how currently after 1945 when the times are more peaceful and the process of childbirth is relatively less stressful, how is that before when stress was more prevalent within people, more great minds are being born, and when stress is not.
I got your answer. I got your question. I think you should ask this question to your grandfather or anyone of his age. I will tell you the answer is, after 45, you have separated the mother and the child. Cesarean rate in South has gone 80%. Tomorrow, Homo sapiens will not even know how to deliver normally. But remember, in nature, everything has a reason. We are talking of epigenetics that is there. During pregnancy, people were far more soft. I have made that mistake. My students, since I teach DM students, so by the time they come join the DM course, they are already married. So I used to punish them for any mistakes, and then I realized that this stress which I am causing actually harms the baby. Let me tell you, the Indian way was far more peaceful, they were far more protected. আজকে একটি মা কি করে? বাড়িতে বসে টিভি দেখে, কোন সিরিয়াল দেখে, এর ওর খুন করে দিয়েছে, এটা এই করেছে, all this produces stress. What do you talk of? Which is the kind of music which is providing you a calmness. You now listen to music which creates excessive adrenaline. Adrenaline causes stress. তোমার নিজের জীবনে দেখে নাও, পাড়াতে যে গানগুলো শোনো, পুজোর নাম করে যে গানগুলো শোনো, কোনোটাতে তোমার হার্ট রেট জাস্ট মনিটর করো। If your heart rate increases, that music is producing stress. If your heart rate decreases, that music is producing you. So actually, with more modernization, you are almost always on your smartphone. You have not even cared that these are electromagnetic radiations. So all this, you are constantly being on it. Odak Mara, I said, why do you fear? Oh, my friend told me on WhatsApp that during pregnancy this can happen. That has not happened, but she is imagining. Unfortunately, that imagination. When you play games, all kind of games have created violence in the child. When the American president asks, why my children here come and shoot in a class for no purpose? The reason is you have wired the brains in such a way. So let me tell you, my friend, we have created far more stress than you can think of. COVID taught you that. Okay. What did COVID do? There was a huge degree of stress. 100 বছর আগে COVID there was another flu in India, Spanish flu. More people died, but there was no panic. So I will not say, and this answer has been given. কোন গাছকে তুমি জল দিয়েছো? যেদিন একটা শিশু গাছকে জল দেবে, the stress levels will come down. This work was done by J.C. Bose, who studied medical science for 2 years. In England, he was demonstrating that the trees understand pain, they understand language. If you water each day and see how the leaves are growing, you actually relax. পাখিকে যখন দেখবে, আকাশকে দেখবে, আজকে 9টার সময় উঠলে আর তুমি বলছো স্ট্রেস নেই, আই এম সরি টু সে, এই জেনারেশনকে এক্সারসাইজ করলে আর going to do some physical exercise doesn't produce you. So it's a long lecture. What have we done to make our life more stressful? That is a different matter. But simplicity, going to nature are some of the basic things which are stress attractors.
Hello, sir. Sir, sir. Late pregnancy. At ninth month of pregnancy, arrangement of oxygen, what is called in Hindi, that is sadbhokon. What is sadbhokon?
What is the important message?
Arrangement of the oxygen, that is sadbhokon. In late pregnancy, in the family, that is sadbhokon. Number one. Number two, presence of husband or near relative during late pregnancy or labor time has influence over the baby development or brain development.
Yeah. So this research I have already published. Let me tell you two things. Don't quarrel with a pregnant. You can make a preamble and write it somewhere. Don't quarrel with a pregnant woman even if she makes a mistake. The simple line will help cognition. Very simple to remember. Second is, during the birth, the mother should choose who should be there. If she is comfortable with her husband, let her husband be there. If she is comfortable with her own mother, let her own mother be there. I cannot choose for her what relaxes her. If she wants to listen Quran, please allow her to listen. If she wants to listen Gita, let her listen. She must know how to relax. But when I did this in a tribal part in Gujarat, thanks to Madam Jayanti Ravi, she supported it. Teenager pregnancy was uncomplicated. Mother was happy after delivery. There was less pain. Delivery, there is something called beta endorphins, which actually gives you a happiness. So let me tell you, we have what was not a pathology, we created a pathology. Pregnancy is not a pathology. Pregnancy is a physiology. It's a normal thing which nature invented for all of us. Even when there was no Dr. Singh, delivery was happening. So I think we have complicated it in whatever way we use.
Good afternoon, sir.
Yes, you wanted
I
to
have a
ask.
question to Naveen Kumar, sir.
Yes.
So you told that in e-health sector, healthcare improvement is very poor. So healthcare, how in West Bengal it can be improved?
Come again, I could hear. Come forward.
So Naveen Kumar sir told that in e-health sector, West Bengal performance is very poor. How can we improve?
Yeah, so first of all, we complain, we have this thing, we always talk about others. First, we should talk about ourselves. So the person it's not just blaming you. Okay, that's the first question I asked on this stage. Please, first question I asked on the stage was, did we do what the easiest thing to do? So as simple as that. So it's about awareness. We should talk. We are all seen. When I talk about, in fact, I was talking when we just paused. If you remember, I used this word champion. The reason I use this word champion on healthcare leaders is each one of you, see, I look at the country at a very different perspective. Okay? We are all the cream of the society. Whoever is sitting in this hall, right? We are the actual cream of the society. The 1% of the society, or less than 1% of the society. And if we do not know what it takes to do it, how can you blame others? That's my simple answer. So you have to become a leader. So if you know that there is something ABBA ID, why can't you go and tell 10 relatives of yours? We do a lot of hundreds of WhatsApp messages every single day, right? Good morning, good afternoon. In fact, I use this for my cancer care. The people who are affected in cancer care, we tell them, why can't you, just, read about something. Maybe talk about the self-examination or talk about cervical cancer. Create a message, because you are already there as a leader in the healthcare. Why can't you make some 5 messages or 10 messages in a month and spread awareness? I did not show the presentation. The starting of healthcare starts with the word awareness, the first A of 6A. If you are not aware, you know that if you are having a stroke, you will probably get a pinch feeling here. And if you do not know that that is the early sign of a stroke, you might not even end up in hospital, you will go dead only. Unless we are aware, we cannot teach people. That's why I do not know how many of you know CPR, how to do a CPR in this auditorium. What if there is an emergency now? These are basics. I call it, in fact when they train, they call it BLS, ACLS. I think for every family member, every person who is sitting here, be it an MBA student, being an MLT, whatever you are, learn these basics. You need to know healthcare basics. It's not like what you talked about. These are basics. I do not know why we complicate things. These are basics. There is a psychologist who is going to talk about it. Most of your problem is solved if you are psychologist. I am a very strong believer in psychology, not in psychiatry. If you talk, if you are able to do it, you can solve many issues. So the word is awareness. So create awareness. And it's not just, West Bengal which is doing that. It's many of the states. I also belong to the UP cadre, you can also see UP there. So you have to talk about it. Unless you talk about it, we do not create a healthy healthcare system. So that's my answer.
Any other questions? Thank you, sir.
Thank you, Mr. Naveen Kumar. I like to have an idea, and I was hearing you going through your slides about the awareness, just you told about the awareness and about things. And you showed a lot of slides about the digital mapping and all these things. What about the telemedicine? So you can also highlight about the telemedicine factors, which is very important. As an optometrist, I think if we improve the work or the modification in the field of telemedicine or telecenter, medical center, that much create more awareness. So I hope you can put some light on it.
See, I'm not a doctor. That's the first thing I always tell. But how do I, bring in that kind of, please listen. So how do I make the change? I'm an IT guy. In fact, the reason I am posted, in fact, I was telling Professor in the morning also, I'm the first digital health secretary in the country. The reason is I have some basics which I learned over the period of time in the last 6 or 7 years. So they thought this guy would come and do it in the digital healthcare, the way you asked me question. We are people who connect dots. If you ask me what is an IAS officer, I connect dots, nothing else. I just connect dots. Andhra Pradesh is also the leader in telemedicine. In fact, we use telemedicine without calling it telemedicine. That's also the way we operate. In fact, your WhatsApp message is also a telemedicine only. We don't have to think of that hi-fi system where you put a video conferencing and all. In fact, if you remember, I do not know, I was in the field when we started operating during the lockdown. How do you conduct trainings for doctors? How do you tell them things are happening? So we started doing all the Zoom conference. This is also telemedicine in a way. I'm just putting it in a different format. So telemedicine is the essential. I think it's the way You look at, I talked about it, right? If you have a cardiologist not in Padero, which is the Hilly station, the nearest, the cardio hospital is somewhere 3.5 hours from the location, or even 4 hours from the location, then possibly that person will pass away on the way to the center. So that's the future. I always believe it is how digital technology. I'll probably give you a small example. What is COVID management? It was bed management. For a hospital administrator, it's a bed management. You have to do a proper turnaround time. You have to ensure the right patients get the bed. People don't do squatting. And when Andhra Pradesh was, not this one, okay, the Andhra Pradesh was separated, we did not have tertiary care hospital. All the tertiary care hospital went to the Hyderabad. So what did our CM do? He started home triaging. Remember this word, I'm using this word called home triaging. What would happen? People will rush as soon as you get a fever, you will go to the hospital. And the influential people will get a bed and squat. That's the word we use, squat. You have 90 SPM, you go and get a bed, that's all. But the people with 20 or 30 will not get a bed. What we started doing is home triaging. We will send people house-to-house surveys. They will condition 3 surveys. Either that fellow needs home isolation, or he or she might need COVID care centers. The third is he might need hospitalization depending on his comorbidities. We were able to do this at the house level. And we would follow using a call center. In fact, we have a call center for 104. We would follow up after the second day. And there's a lot of psychological problem which happens. This guy we have told him stay at home. Or this lady we have told them stay at home. And then they'll start getting WhatsApp, SMS and all. Then they'll start panicking. In fact, I believe most of our illness can be managed if you are psychologically strong. In fact, I know an uncle who was 20 SPM and still alive. So that's the way you should, it's not just, and there are people who are 80 SPM who are passed away. So you have to create the system. So when you put it, I call it designing the system. It's important when you are doing that, all your engineers who are sitting here, you go there, design the system with whatever you have. Remember this one, you will not get everything on board. So you have to be a design thinker. So that's exactly what my chief minister did. He was able to put a system, and Andhra Pradesh is only state which never had a lockdown in Delta, the second wave. So I was there around that time because we were able to do it. Confidently we were moving. Because we had a controlled and a well-designed system. We didn't have a lockdown, imagine. We didn't have a full day lockdown. We had a morning lockdown, that's all. Morning means 2 p.m. to 6 a.m. in the morning. That's how our work. Other time we were working. And it's only state, probably Punjab was the other state which had was closer to it. But we had a system to manage. So hospital administrators who are sitting here, who will be studying, you have to talk about bed occupancy ratio. TATs, when you manage emergencies, your turnaround time is the most important thing. Doctor like him is very, very highly valuable. Will I use only 20 minutes of his time or 2 hours of his time? This doctors will not decide. You as an administrator will decide. So remember, you have to make profits for you. In fact, that's what you'll be doing. You'll be making profits for your company. But remember this one, it's not just profit. It is this time, I see it the other way around. It is this time which is important. Can we take 10 hours of his time, treat 20 people with that 10 hours of time, or just treat 5 people with that time? So that is what you guys will manage. So please go there to your institution, talk about turnaround time. That's more important. Thank you.
We close the session here. Thank you, sir.
I now call upon our first keynote speaker of this session, Professor Dr. Shautadol Saha, MS, FRCS, former Professor, School of Medical Science and Technology, IIT Kharagpur, to deliver Dr. Bidhan Chandra Rai Memorial Lecture.
Is self-explanatory. It is not something that I have coined. I have taken it from His Holiness the Dalai Lama. Today we are at a time when we have more medicines, but we are less healthy. Many of you must have seen this newspaper heading about 2 months months ago, sometime in October 2022, that SSK Hospital, teaching hospital, set a new record of seeing 17,000 outpatients in a single day. Big news. All major newspapers front page. The question that I want to ask you is this something we should be proud of? Is this something we should be ashamed of? Ashamed because where are these 17,000 patients coming to attend a hospital in a single day, and that's just one hospital? Why is the nation so unhealthy? And second, even if I assume that 200 doctors were sitting in the outpatient at SSKM on that day, each doctor saw 85 patients during the OPD hours, which would be how many hours? 4 hours, 5 hours? So in 5 hours, you are seeing 85 patients, that is 17 patients in an hour. Patients come with hope and faith that they would be seen and examined by the doctor. Is it physically possible? To me, it's a matter of shame if our hospitals are as busy as this, 17,000 patients a day. Now, why is this happening? This is happening because of what we call health inequity that is all pervasive, not just in India. Today, 50% of the world's population, that is almost 4 billion people live without access to proper health care in different parts of the world. And 100 million people every single day have to choose between whether they will buy medicine or they will buy food based on the money that they have left. Equity is different from equality. We will not go into that argument today because equity and equality is another talk by itself. And common reasons to which the health inequity in India has been ascribed to. We are short of doctors 600,000. We are short of allied health professionals, which includes community health workers, which includes healthcare technicians, almost 50 lakhs. Informal medical practitioners constitute 80% of those who practice medicine in rural India. The medical technology, diagnostic, therapeutic that we use in our country, 80% of that is imported, and therefore these do not work in the resource-constrained rural environment that our villages have. And please remember, 70% of India is rural. There may be infrastructure on the record, but 50% of the healthcare infrastructure in our country is underperforming because it is an incomplete infrastructure. And then we have a misdirected focus where we think hospitals, more and more hospitals are the be-all and end-all of the solution. We neglect public health, which truly public health forms the central core of health system. And during COVID, we all saw how the deficiencies in the public health system in different countries, not just India, led to that kind of an havoc. We have a misdirected focus on curative care. We do not focus on primary care and public health. And it is the combination of these reasons that give rise to a crushing health inequity, which leads to increase in the societal disease burden, which leads to 17,000 patients coming to our hospital every single day. Now, we need more doctors. Everyone knows that. You don't have to be Einstein to figure out that India needs more doctors. Neither do you have to be an Einstein to understand that we need more hospitals. But more doctors and more hospitals, is that going to solve the problem? doctors we have, the more we will have maldistribution. There are 5 states in India where the doctor population ratio is as per WHO standard. But even in those states, the rural-urban distribution discrepancy is the same as in other states, because doctors from villages do not go back to villages. They prefer to live in the city or in the urban fringes, and therefore by producing more and more doctors in India, we will not be able to address the problem of availability of doctors in our villages. And therefore, the reason why I'm saying this, when we talk about science and technology is simply a tool. It is nothing more than that. What I'm trying to do is establish the context as to how science and technology will solve the problem. So the one problem that you have is doctor shortage and doctor maldistribution. Similarly, we can set up as many hospitals as we want. If those are bad hospitals, they will be underutilized. If they are good hospitals, they will be overfull, like 17,000 patients every day, because the perpetuity of the health inequality keeps the disease engine going in the society, and it keeps on improving the disease burden. So what he will be doing, কারুর বাড়িতে কুকুর আছে এখানে, পেট ডগ আছে কারুর বাড়িতে, you have one. What about the students? এই তোমাদের কারুর বাড়িতে পোষা কুকুর আছে? You have. আছে? কুকুরের লেজটাকে টেনেছো কোনোদিনও? কারণই টেনে সোজা করতে পারবে? So, by setting up more and more hospitals, we will be trying to straighten the dog's tail, something that cannot be achieved. So, this is not the answer. It is needed, but it is not the answer that we are looking for. Game of Thrones দেখনি কে আছে এখানে? Game of Thrones দেখনি কেউ আছে? একজন, দুজন, আর তিনজন, আর 4, 5, 6, 7, 8, 9। এই ঘরে এখন হয়তো 100 জন লোক আছে, 9 জন দেখেনি, মানে 80% দেখেছে। টাইরিয়ন ল্যানিস্টারের লাইনটা মনে আছে? It's the story that stays. So, there has to be a personal motivation behind everything. When I came back, having trained as a surgeon from UK in 1995, for the first 15 years, I did what all doctors do, which is operate, operate, and operate. I was only a doctor at that time, and these 4 hospitals were set up. Professor Sarkar knows about all of this, in different districts of West Bengal, which provided what I believe affordable super specialty service to the districts and rural population. But then things changed. So I came across this 83-year-old woman suffering from chronic renal failure in the year 2009. She has a poor quality of life and has to spend about 15,000 rupees every month on medication, like 20-25 medicines. She has a renal failure today because she was suffering from urinary tract infections since childhood, which was unaddressed. When she was a child, her parents did not have the money to seek medical care, so poverty prevented her access to health care as a child. In her adult life, when the pressure of poverty wasn't there, she did not even know that UTI is a real problem that needs medical attention. So lack of awareness prevented her medical access when she had the financial means to do so. And therefore, that's a double whammy. She is my mother. You have to find the personal motivation behind everything that you do. This is what I meant, that unless we are able to create equitable access to evidence-based primary health care, unless we are able to implement solid public health programs and implement them and measure them what they are achieving by setting up more and more hospitals, we will simply be contributing to a more and more unhealthy society and just making money for a few people. That's what we would do, straightening the dog's tail. Now, what I am saying is not something new. I did not discover any of these things that I am saying. It's all there for everyone to read, for everyone to know. But how? That's the holy grail of healthcare. That's the holy grail of health system. How science and technology can address these problems is what this talk is all about. This news is 2 days old. Even the Supreme Court says government has to provide rural health care. It says 80% specialist shortage in villages. So now let's understand how this can be possible. So in 2010, I left conventional healthcare, hospital-based healthcare, and I became a community healthcare person from 2011. And over the first couple of years, through experiential learning, we developed a hypothesis. It was only a hypothesis that if we can train enough rural youth as certified, skilled professional health workers, both at the community level and to meet the shortage in the health system, if we can shift some of the tasks from the doctors to these health workers and thereby reduce time per patient per doctor and reduce the need of the doctor to travel and stay in villages where they don't want to go and stay, and if we can supplement this whole system with frugal, disruptive, deep science, science and technology innovation, what we call a 3T model, training, task shifting technology, maybe we can have a solution. On your left, what you see is an ECG device. এখানে কে আছে ইসিজি মেশিন দেখেনি কোনোদিন? ইসিজি মেশিন দেখুনি কজন? How many of you? একজন, দুজন, তিন, few, মানে বেশিরভাগই দেখেছো, রাইট? ইসিজি মেশিনের তার থাকে অনেকগুলো, দেখেছো? অনেকগুলো তার এখানে লাগাতে হয়। That's the problem. ওই তারগুলো লাগানো, ঠিক মতো লাগানো, কোনটা কোথায় লাগবে, that's the problem. This ECG machine does not require any wear. এটার কোনো লিড নেই। এটার দাম 2,500 টাকা। And this can do a 12-lead ECG just as well as an 80,000 rupees Hewlett Packard or GE ECG machine will do. And this is what I mean by disruptive frugal innovations, that science has to be looked in a different way. And because it doesn't require leads, everyone can do it. I can teach you in 10 minutes. Any of the students here, আমাদের ডাক্তার হওয়ার কোনো দরকার নেই, হেলথ ওয়ার্কার হওয়ার কোনো দরকার নেই. I can teach you how to do an ECG in 10 minutes using this ECG machine, which costs 2,500 rupees. Not a penny more, not a penny less. So with this hypothesis, we started working at a place called Shalboni in West Midnapur in Jambul Mahal. And here is a small glimpse of what we did. Her name is Navanita. These are not props, these are real people. Navanita is a class 10 pass from Shalboni. Today, Navanita and 8 others are the messiahs of home health care, basic support, wound dressing, intramuscular injection, simple things like that to a wide area of Shalboni covering 28 villages, including some of the villages in Jangalmahal. And most important, after this training and after Navanita started doing this, she actually married a man of her own choice, something that this is called disenfranchisement to enfranchisement. For a class 10 pass girl from that village and that background to decide to marry a person of her own choice is in itself reflects the power that came from within her, and that power, source of that power, lay in the capacity that has been built. So, when we started hypothesizing the 3T model and we created a small example at Shalboni and we show that it worked, there is a thing called lean startup approach. You can't address all the problems in the world. Even for a single problem, there will be 10 reasons. You cannot address all the 10 reasons together. If you try, you will fail. This is called the lean startup approach. So choose what are your biggest problems. The two of the biggest problems that we understood at that time was shortage of health human resources. We see, I'm not talking about doctors anymore. Doctors are essential for healthcare, but we cannot remain over-reliant on doctors to be able to reach healthcare to the nooks and crannies of a country as diverse and as big and as fragmented as India. Thousands of dialects, hundreds of religions, jungles, mountains, snow, sea, river, everything is there. And second, healthcare cannot be practiced without technology, and the technology that we are using are all imported. None of them is suitable to be used in the Indian context, except for one person sitting there who built technologies that can be used in the Indian context. So on technologies, there will be two areas that we focused on. One is data science. Now, what do I mean by data science? Indian health sector is data thin, which means very little data is available in the health sector in India. From data thin, we need to move to a health system that is driven by data, where data is the principal driving factor. Data in India is taken in certain points in time, and the data remains frozen in that point in time. We need to make sure that the data is dynamic, that the data flows from 13 years ago to 6 years ago to today to 4 years later, how that data behaves. Data collected in isolation, frozen in time, cannot give you that analysis. Therefore, the data that we collect can be compiled into tables, which is good for statistical purposes, but it cannot be analyzed. Because to be able to analyze the data, it must conform to certain standards, certain languages, certain structure. The softwares, the medical software that we have is of a fixed nature, where the patient is asked a certain set of questions. We need to move to decision support system, where there is a clinical algorithm that varies according to the patient's age, gender, occupation, symptoms, because that's how a doctor asks questions. The data system must be bandwidth agnostic. It doesn't matter if you have 10 kbps, it must operate even in a 10 kbps situation. And like I said, India has so many languages, it must also be language agnostic. Language agnostic, location agnostic, dynamic, analyzable, longitudinal, algorithmic data is the future of health, and health will be driven by data in this manner. Because I was asked to talk about science and technology in this. Then you talk about devices. We need various equipment. By asset, I mean diagnostics. So devices and diagnostics. You must make sure that the device that you want to innovate meets a certain need. Innovation cannot be driven by what you want to do. It needs to be driven by what is needed by the people. We must be able to switch from electrical power sockets to battery operated technologies. We must move from equipment that require multiple complex steps to single step or few steps, because then it is easier to train a rural community health worker. The person will use it. We must reduce reliance on venous blood for testing to capillary blood for testing, because drawing venous blood is an art, is a skill that is not easy to train, and a person who knows how to draw blood from a vein will not live in a village, will move to a city because there is shortage, and he will get more salary, so he will move. So we need capillary blood draw, which is a simple skill which can be taught to many, many people. And then there are issues of data integration from the devices. And then never ever say low cost. There is nothing called low cost. The term low cost is a humiliating term. Because what you are trying to tell the villager is that I am going to use a low cost device for you. It is a humiliating, there is a bad connotation to the term low cost. We talk about affordability. Affordability is a relative term. What is affordable for me may not be affordable for you. What is affordable for you may not be affordable for another person. And therefore the technology needs to be such, if it is meant for you, it is affordable to you. It should not be called low cost. And this is where about 5 to 6 years ago, the concepts changed. We figured out in IITs that affordable technology, simple technology does not have to be, and this is very important, it does not have to be brain damaged science. On the contrary, you need to master science to the extent, you need to apply science in an exalted manner. You need to really unravel the deepest mysteries of science to figure out how science can be used for human benefit, for common people's benefit. We call it deep science. It must be disruptive. There is a certain conditional thinking that you have. These are called boundary conditions. The innovation must be such that it disrupts all the boundaries in the mind. It helps you to break down the barriers in your own mind that have been due to social conditioning as you have grown up. Think beyond, which is sometimes called thinking out of the box. And frugal, we never say cheap, we never say low cost, we say frugal. The frugal connotation is it does everything that it is meant to do, it does everything as well as it is meant to do, but it does things at a cost, not price, which is affordable to the people for whom it is meant. So in the IITs now, we now have a stream which focuses on deep science, disruptive, frugal innovation of technologies that meets the need of the people for whom it is meant and operates in the environment in which it is supposed to be used. So I said in the three T's, training, task shifting and technology. So you all can figure out, that's the picture of a tea garden in Jalpaiguri. And in the picture below, you see tribal boys and girls whose parents are all tea garden workers, and those of you whom you do not know, tea estate workers are examples of one of the most deprived and one of the most disenfranchised communities in India. Tea estate workers, those who pluck 2 leaves and a bud. You all must have heard 2 leaves and a bud. And in the picture below, you see these boys and girls. They got jobs in hospital in Bangalore, and for the first time in their villages and for the first time in their families, a group of 12 young boys and girls left those villages in search of a job in the city of Bangalore, and they are working in one of the largest hospitals in Bangalore. That's the power of training. School for Skills Allied Health Sciences is what our training facility is known as. Over the last 10 years, between 2013 and today, 2023, years, we have expanded from West Bengal to 6 states in India through 10 schools. Over 4,500 have been trained, and interestingly, over 60% are girls, because in healthcare, it preferentially employs women. Are from low-income families. And our key employers are Tata Medical Center, Apollo Hospital, and MS Maya. That's the power of training. It makes people. Now talking a bit more about data science. See, how does a doctor see a patient? A patient comes and tells the doctor, "Amar jor hoyeche." Then the doctor asks the patient a question. Based on the answer to the patient's question, the doctor asks the second question. And then at one time, the doctor does not have any other question to ask. And then the doctor undertakes physical examination. And then the doctor makes a certain possible diagnosis. How is he making the diagnosis? We call it deconstruction, reconstruction. So there is a deconstruction of the patient's symptom, jor. And the answers that the patient gives is reconstructed into a possible diagnosis. So this is what we thought in 2014-15, that a doctor's mind works using a reconstruction algorithm. So why can we not develop a decision support software that works according to the reconstruction principle? We discarded MATLAB, we discarded IBM, we worked together with Johns Hopkins University, and over a period of 3 years, 2015 to 2018, 6 engineers from their side and 4 from our side, we lived in villages. আমরা সুন্দরবনের জঙ্গলে গিয়ে থাকতাম, বীরভূমের বর্ডার অত্যন্ত গ্রামে গিয়ে থাকতাম, to understand there is a thing called design ethnography, which I will explain later. To understand the design ethnographic considerations behind developing a software. See, building a software will give me a significant intelligent kick. I feel good. Look, this is what I've done. But what is it doing to the people? Ultimately, that's all that matters. How many claps you get or how many papers you publish, I'm not saying are unimportant, but more important is the people for whom you are doing it, are they benefiting? And finally, we ended up with this clinical decision support system. And our conjecture was, well, these are not conjecture, these are facts. In good textbooks of medicine, you will find that 90% of the reason why a rural person tries to seek medical consultation is in the primary care domain, not even secondary care, forget about tertiary care. And 70% of primary care illnesses, if there is a good history, if there is a basic physical examination, and if I can have basic tests, 70% of primary care illnesses can be diagnosed with a reasonable degree of certainty, which will allow me to develop a clinical management plan that is safe and that is evidence-based. I'm not interested in diagnosis. The patient is not interested in diagnosis. A patient is interested in getting better. So what gets the patient better? I don't care whether there is a diagnosis or not, in a manner that is safe, that is evidence-based. That's what we focused on. And when a doctor examines you, সবাইকে এখানে কোনো না কোনো দিন ডাক্তার দেখিয়েছো, ডাক্তারে হাত টিপেছে, মাথা টিপেছে, পায়ে এসব করেছে। 50% of those examinations are skill-based examinations, which can be taught to a professional health worker. So this is how we moved away from, somebody asked a question earlier, telemedicine. Thank you. So in telemedicine, there is a doctor at that end, there is a patient at this end, and there is a very high-end infrastructure in the middle. The doctor is consulting the patient. Doctor's documentation is very poor. Those of you who have seen prescriptions written by doctors, they write nothing. Zero. Because they have to see 85 patients in 4 hours. So what are they going to write? So no documentation of actionable health data. And 600,000 doctors short. So we need to decrease the consultation time. Otherwise, how are we helping the system? there is no decrease in conservation time. High bandwidth requirement, large infrastructure. In a telemedicine, the patient is not being examined, and there is a language and communication barrier. So what we say, time has come and India is moving away from telemedicine and transforming to a digital health model where, as I explained earlier, in the software development, there is complete clinical information. There is less time and improved quality because 7 to 8 minutes of the doctor's task has been taken away by the technology. It is comprehensive, the data is analyzable using ML algorithms and artificial intelligence embedding. So this is the final interdisciplinary translational innovation ecosystem. We are all faced with chaos in the country. We all have constraints in the country. Add creativity to that, and that is the 3C of innovation. Chaos and constraint are the triggers for innovation, for which you need a creative mind. And we need to move away from blue sky research that advances science to R&D that solves the real life problem. We have intelligent people in our country who work in their own silos. We need to break down the comfort zone of a silo and put people together to foster interdisciplinary research. And we need to convert our academic institutions into centers of excellence. And excellence is a philosophy. Excellence cannot be structured. Excellence is a state of mind. So using this 3D model, we developed 47 digital clinics that are operating in different districts of West Bengal now, including a fully equipped motorboat at Sugarboat, where 174 certified people are employed and are delivering healthcare to 24,000 patients every year through 6 general practitioners and 7 specialist doctors. This is how the system works. Philosophy of the mind is the driver of science. Science is a passenger. I know many of you here are from humanities background, but everyone has a role to play. And I think the design ethnography, the medical medical social anthropology, the diffusion of innovation into the community, designing, formulating public health policies, health economics, the enterprise process, and monitoring and evaluation are all subjects that are embedded in humanities, and it is this awareness that will drive the application of science and technology. Science does not have primacy. Mind has the primacy, and mind is driven by the philosophy that you hold close to your heart. This is why we are currently present. And if you see the small map, the states in orange red are the states with high poverty index. And we are as much as possible trying to follow that signal. These are the 7 states in which we are working now in different forms or other. This is the team that works, which makes it possible for me to talk. Some of my team members are here. And I came here almost 40 miles from my home, looking for merchants of dream who will think, innovate, change, modify, and then go out into the society and say, I'm here to make a change. Thank you.